साधारण कुराकानी गर्दाखेरि चाहिँ हाम्रो फोकस यो फेसबुकमा हुनुपर्छ भन्ने कुराहरूको चाहिँ उहाँको चाहिँ मेजर इन्डिकेटर्स यो हो Chinese context goals चाहिँ फिमेलहरूलाई चाहिँ त्यही सिकिन्छ त्यही आइडेन्टिफाई हुन्छ तर यो चाहिँ हेर्नु साउथ सोसियल नेपालकै गरिन्छ चाइनाको इस्यु है अर्को चाहिँ एज फर नेपालले राजाको यो फिमेलको 18.5 चाहिँ मेलको 22.3 देखिन्छ अब यसको सालमा गर्दाखेरि हामीले देख्छौँ भन्दाखेरि सेक्सुअल एक्टिभिटीज नेपालको मात्रै एजुकेसन रेफरेन्स गरिएको इन्ट्रेस्टिङ फ्यामिलीज फर्स्ट सेक्स चाहिँ फिमेलको एजमा चाहिँ अलमोस्ट मिडियम एज फर फर्स्ट सेक्स एन्ड मिडियम एज फर फर्स्ट म्यारेज चाहिँ 25 वर्ष तर मेलको एजमा चाहिँ फर्स्ट सेक्सुअल इन्टरकोर्स चाहिँ 20 वर्ष 20.7 मा भएको छ भने उसको म्यारेज चाहिँ 22.3 मा देखिन्छ मिडियम एज यही इन्डिकेसन गरिरहेछ होइन सेक्सुअल एक्टिभिटिज going on in the middle setup तर यो यही अर्को सेक्सुअल इन्टरकोर्सको ट्रेन हामीले हेर्ने हो भने चाहिँ यो डिक्रिजिङ ट्रेन छ 1996 मा कम्पेयर गर्ने भने हाम्रो डिक्रिजिङ ट्रेनमा छ सकिन्छ र सेक्सुअल एक्टिभिटिज चाहिँ फिमेलहरूमा हेर्ने छ यो सेक्सुअल एक्टिभिटिजसँग थुप्रो ओर्गन्सहरू जोडिएको छ त्यसबाट यो अलिकति अलार्मिङ सिचुएसन हामीसँग छ अब यो सेक्सुअल फिजिकल भाइलेन्सको एउटा रिसेन्टली रिलेटेड प्रोफेसरको हेर्दाखेरि के देखिन्छ भने ग्लोबल हेरिटेजमा चाहिँ यो लाइफटाइममा फिजिकल सेक्सुअल भाइलेन्सको रेट चाहिँ अराउन्ड 27 छ भने यो 1 वर्षको कुराले गर्दाखेरि चाहिँ अनि यो चाहिँ सिग्नल सेक्सुअल एक्टिभिटीको भाइलेन्सको चाहिँ देखिएको छ त्यो चाहिँ 37 र त्यसपछि 22 देखिन्छ र नेपाली कम्प्लेक्सको विषयले कम्प्लेक्समा हेर्ने हो यो चाहिँ अलमोस्ट 4 वर्षको एजेसको प्रयासमा कि हाम्रो चाहिँ अलमोस्ट चाहिँ सेक्सुअल फिजिकल भाइलेन्सहरू चाहिँ हाम्रो कम्युनिटीहरूमा भइरहेको छ त्यसैले सेक्सुअल भाइलेन्स is very close indicator for sexual reproductive rights. त्यसैले यो भाइलेन्स कन्टिन्युअसली हाम्रो भइरहेको छ त्यसैले we have to be aware about this matter. अनि यो अहिलेसम्म कम्प्लिटली नेग्लेक्टेड हाम्रो लेबरहरूले पनि सपोर्ट गरेको भनेर चाहिँ सिडीको बिलहरू पनि सपोर्ट गरेको चाहिँ यो एडल्ट सेक्सुअल फङ्सन्सको कुराहरू चाहिँ सपोर्ट गर्छ त्यो is also very important issues र यो लाइफ एक्सपिरियन्स बोलेको छ भने हामी सेक्सुअल फङ्सन्सको कुराहरू पनि जोड हुन्छ र त्यो आधारमा हेर्दा पनि छ भने चाहिँ अब यो 21 इन्जुरिजहरूको एनालाइसिस गर्दाखेरि अब उनीहरूमा चाहिँ around half of the 50.75% of the womenमा चाहिँ sexual dysfunctions देखिएको छ यो एडल्ट्सको डिफ्रेन्ट भेराइटिजहरूको उहाँको चाहिँ सेक्सुअल डिस्फङ्सन्सहरू पनि हेर्नुभयो भने त्यो 3 भन्दा बढी छ भने 25 to 21 एजमा चाहिँ डिफ्रेन्ट खालको एजहरूले सेक्सुअल डिजायर एडिक्सन्स सँगसँगै चाहिँ प्रब्लम्सहरू छ त्यसैले यो चिज चाहिँ अलमोस्ट erectile dysfunctionको इस्यु चाहिँ इट्स ह्युज बट भेरी साइलेन्ट त्यसको कारणले गर्दाखेरि हुने अरू चाहिँ भाइलेन्सको कुराहरू त हामीले एक्सपोजै गर्न बाँकी छ तर यो ग्लोबल डाटा हेर्दाखेरि पनि अराउन्ड 43% चाहिँ मेलहरूमा यो प्रब्लमहरू देखिएको छ त्यसैले पनि सेक्सुअल एन्ड रिप्रोडक्टिभ हेल्थ एन्ड राइट्सको
कन्ट्रासेप्सनको युजको कन्डिसन हेर्ने हो भने पनि हामी ग्लोबली अथवा साउथ एसियासँग कम्पेयर गर्ने हो भने चाहिँ सबै इन्डिकेटरहरूमा चाहिँ तलै छौँ यो 37 अब हाम्रो एनडिएचएसले चाहिँ अराउन्ड 43 भनेको छ मोडर्नमा यो माथिको मोडर्नमा हाम्रो 32.9 छ यो चाहिँ भर्खरै निस्किएको यो मेजरिङ कन्ट्रासेप्टिभ मेथड भर्खरै त होइन यो अलिकति अगाडिकै हो तर ल्यान्डसेटको सिरिजबाट ग्लोबल एनालाइसिस गरेको डाटा हो मैले माथि भनेको र एनडिएचएसको डाटा पनि मैले यहाँ राखेको छु यसले के देखाइरहेछ भन्दाखेरि कन्ट्रासेप्टिभ प्रिभेलेन्स रेट चाहिँ हाम्रो एक्सपेक्टेड छैन यो अहिले चाहिँ थोरै नै छ भन्ने हिसाबमा हामीले यसलाई बुझ्यौँ भने राम्रो हुन्छ अब एबोर्सनको डाटा चाहिँ यो स्टार इटिएलहरूले 2018 मा एउटा चाहिँ ग्लोबल एनालाइसिस गरेको रहेछ त्यसले के देखाइरहेछ भने about 44% of all pregnancies worldwide are unintended and some 56% of unintended pregnancies end in an induced abortion मा जान्छ भन्ने कुराहरु चाहिँ इट्स अ ग्लोबल पिक्चर हो अब नेपालको चाहिँ अनफर्चुनेटली 2016 को एनडिएचएस मा चाहिँ एबोर्सनको इश्यूजहरु इन्क्लुडेड भएको थियो अस्ति मैले मरिमरि खोजेँ त्यो भेटिन मैले मिस गरेँ कि त्यो क्वेशनै मिस भयो थाहा भएन एनडिएचएस मा मैले देखिन तर यो पुरानो डाटाबाट हेर्दाखेरि के देखिन्छ भने यो सम्भवतः यो एउटा चाहिँ नेपालको एउटा लिफलेट बनेको रहेछ त्यसमा हेर्दाखेरि के देखिन्छ भने 2 in 5 women of reproductive age are aware about the legalization of the abortion in Nepal legalization भएको देखिन्छ 29% of the facilities that offer normal vaginal delivery services have medical abortion services and 11% offers comprehensive abortion care 50% of pregnancies are unintended in Nepal and among them 62% ended in abortion यो चाहिँ अहिलेको ग्लोबल फिगर भन्दाखेरि हाई देखिन्छ it is estimated that 323,000 abortions were conducted in 2014 अलिकति पुरानो डाटा हो 58% of them were conducted in clandestine manner हैन मेरो अलिकति clandestine manner भनेपछि यो एबोर्सनको डाटा पनि हाम्रो चाहिँ अलिक खाली लाग्दै खालको डाटा चाहिँ देखिन्छ दिस इज अल्सो अ पार्ट अफ एसआरएचआर एचआईभी एसटीआईज इट्स ह्युज प्रब्लम हामी कहाँ पनि अहिले अलिक कम गफ गर्छौँ तर पनि एसटीआई र एचआईभी यो बुमिङै भइरहेको स्थिति देखिन्छ अब मलाई त एकदमै डर लागेको कुरा चाहिँ के छ भने 40.4 मिलियन मान्छेहरूले एचआईभी को कारणले संसारमा ज्यान गुमाइसकेका छन् त लास्ट लाइन मात्रै मैले कुरा गरिरहेको छु हैन अहिले पनि 39 मिलियन पिपल चाहिँ दे आर लिभिङ विथ एचआईभी र यो नेपालको पनि कन्टेक्स्टमा हामीले कन्ट्रोल त गर्यौँ न्यू इन्फेक्सन्सहरू कन्ट्रोल त भइ नै रहेछ तर पनि यो चाहिँ स्टिल पब्लिक हेल्थ प्रब्लम एसटीआई को कुरा गर्दाखेरि त ग्लोबली यो पनि गचमाचर लान्सेन्स कमिसनमा निकालिएको रिपोर्ट हो 358 मिलियन पिपलहरू चाहिँ यो चारवटा मात्रै एसटीआई को यहाँ हामीले लिँदाखेरि पनि 358 मिलियन पिपल चाहिँ इन्फेक्टेड छ अब त्यसमा त एउटा अर्को इन्ट्रेस्टिङ डाटा पनि छ यहाँ त्यो 1 मिलियन पर डे चाहिँ एसटीआई को इन्फेक्सनहरू भइरहेको देखिन्छ है इट्स अ ह्युज त्यो चाहिँ ग्लोबल डाटाको कुरा गरेको हो अब रिप्रोडक्टिभ क्यान्सर्स यो पनि अहिलेसम्म हामीले चाहिँ हाम्रो एसआरएचआरले समेट्न नसकिएको हामीले एसआरएचआर भनेको चाहिँ खालि सेफ अफ मदरहुड ब्ला 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 एडोलेसेन्ट हेल्थ आदि इत्यादि मात्रै कुराकानीहरू गरेछौँ तर एडल्ट मेल एन्ड फिमेलमा हुने खालको यो रिप्रोडक्टिभ क्यान्सर्सको कुरा चाहिँ इट्स बर्निङ इस्यु र त्यसलाई हामीले एड्रेस गर्नुपर्ने देखिन्छ एभ्री इयर 2.7 मिलियन वुमेन डायग्नोस्ड विथ द गाइनोकोलोजिकल एन्ड ब्रेस्ट क्यान्सर्स 1 मिलियन वुमेन डाई अफ दिज कजेस अनि मेलहरूमा पनि के देखिन्छ भन्दाखेरि 1.1 मिलियन मेन वर्ल्ड वाइड वर डायग्नोज विथ द प्रोस्टेट क्यान्सर्स इन 2012 यो चाहिँ मेनहरूमा हुने क्यान्सर्सहरूमा सेकेन्ड क्यान्सर इज प्रोस्टेट क्यान्सर्स यसलाई हामीले रिप्रोडक्टिभ क्यान्सर्सको रूपमा मानिन्छ अस्ट्रेलियन सेक्सोलोजिस्टहरूको एउटा कोड स्टडीमा त के देखिएको छ भन्दाखेरि चाहिँ इफ अ पर्सन डु अ मास्टरबेसन रेगुलरली अर डु अ सेक्सुअल एक्टिभिटिज सफिसियन्टली यो प्रोस्टेटको क्यान्सरलाई ड्रास्टिकली रिड्युस गर्न सकिन्छ भन्ने फाइन्डिङ्सहरू छ होइन। त्यसैले इट्स रिलेटेड विथ द सेक्सुअल एक्टिभिटिज अफ द पिपल अल्सो। त्यसैले दिज आर दि म्याटर्स द्याट वी हेभ टु टेक केयर वेन वी टक अबाउट एसआरएचआर। अब त्यसैले नर्थ सेलमा मैले कुराकानीहरू गर्दाखेरि चाहिँ ओन्ली 57% अफ द वुमन मेक इन्फर्म डिसिजन्स अन सेक्सुअल रिलेसन्स, contraception use and reproductive health care. A woman dies every 2 minutes due to pregnancy or childbirth. Among the 1.9 billion women of reproductive age, 270 million cannot access contraception. Disruption in access to family planning services during the COVID-19 pandemic resulted in approximately 1.4 million unintended pregnancies and a 30% increase in reported cases of gender-based violence. यो COVID-19 को कारणले गर्दा बढेको र अहिलेसम्म पनि त्यसको इम्प्याक्ट चाहिँ इट्स कन्टिन्युअस। त्यसपछि approximately 73 million induced abortions takes place each year and almost half of all abortions are unsafe. 1 in 3 women across their lifetime have subjected to physical and sexual violence by an intimate partner or sexual violence by a non-partner. Non-partner को violence चाहिँ संसारभरि नै कमै रहेछ, around 6% मात्रै छ। नेपालमा पनि non-partner sexual violence चाहिँ कमै देखिएको छ, it's below 1. अब over 1 million sexually transmitted infections are occurred every day. यो चाहिँ असाध्यै alarming चित्र लाग्यो मलाई। Almost 500 million girls and women lack access to services and products for managing their menstruations.
अब यहाँ घन्टी बजाउने रहन्छ,
घन्टी नबजाउने भएको र फटाफट लगिहाल्छु। अब 3टा स्लाइड छ है। त्यसैले अब यो टोटलमा एसआरएचआर को फ्याक्टर्सलाई इफेक्ट गर्ने कुराहरू के हो त भन्दाखेरि इन सर्टमा चाहिँ चेन्जेस इन साइज एन्ड कम्पोजिसन अफ पपुलेसन, भल्नरेबल पपुलेसन बढेको छ, लाइफ एक्सपेक्टेन्सी बढेको छ, अनि बिहे गर्ने उमेर पनि बढेर अहिले चाहिँ टु लेट म्यारिजको कारणले गर्दा देयर आर कम्प्लिकेसन्स होइन। यो चाहिँ पपुलेसनमा आएको चेन्ज सँगसँगै अब एसआरएचआरमा पनि चेन्ज आएको छ। इरेक्टाइल डिस्फङ्सन्सको, सेक्सुअल डिस्फङ्सन्सको पनि कुराहरू चाहिँ यो चाहिँ लाइफ एक्सपेक्टेन्सी बढ्ने बित्तिकै देयर आर लट अफ इस्युज, रिप्रोडक्टिभ क्यान्सर्सको कुराहरू पनि त्यसमा आएको छ। डिस्प्लेसमेन्ट र कन्फ्लिक्टको कारणले गर्दाखेरि पनि एसआरएचआरमा ह्युज प्रब्लम। 58 मिलियन पिपल दे आर डिस्प्लेस्ड र तिनीहरूमध्ये 75% चाहिँ वुमन र गर्ल्स अथवा एडोलेसेन्ट पिपल र गर्ल्सहरू छन्, के अरे वुमनहरू छ 75%। त्यसो भएको हुनाले पनि देयर आर लट अफ इस्युज। त्यसपछि क्लाइमेट चेन्जको कारणले गर्दाखेरि पनि एसआरएचआरमा चाहिँ डाइरेक्टली और इन्डाइरेक्टली चाहिँ इम्प्याक्टहरू भएको छ। अनि सोसियो इकोनोमिक एन्ड कल्चरल डिटर्मिनेन्ट्सले पनि स्टिल लट अफ मिसकन्सेप्सन, मिथ्स अनि राम्रा कुराहरू पनि छन्। एजुकेसन भएको मान्छेहरूको एसआरएचआर स्टाटस राम्रो छ, अनि एजुकेसन नभएको मान्छेको एसआरएचआर स्टाटस एकदम कमजोर छ। त्यसैले दिज आर द थिङ्स द्याट वी हेभ टु लुक इन्टु। लज, पोलिसिज एन्ड प्रोग्रामहरूले पनि एकदमै संसारभरि र नेपालमा त हामी त लको हिसाबले त अथवा लिगल एरेन्जमेन्ट
हामीले फेरि डिस्टर्ब गर्नु पर्यो तपाईलाई।
ल
प्लिज र्याप अप गरिदिनुस्।
सक्यो। अब एउटा फोकस हियर। त्यसैले दिस इज द कन्क्लुडिङ स्लाइड कि त्यसो भए पनि हामीले केमा फोकस गर्ने भनेर नैरोबीको आइसिपिडी 25 को कन्फरेन्समा दिज आर द इस्युज द्याट वी हेभ टु फोकस वेन वी टक अबाउट एसआरएचआर भन्ने कुराहरू छ। मैले यसलाई पढिनँ किनभने 2 चोटि वार्निङ आइसक्यो, अब कुटाइ नै खाइन्छ भन्ने डर भयो होइन। टु एचिभ द युनिभर्सल एक्सेस टु सेक्सुअल एन्ड रिप्रोडक्टिभ हेल्थ एन्ड राइट्स एज अ पार्ट अफ युनिभर्सल हेल्थ कभरेज चाहिँ हामीले दिज आर द इस्युज द्याट वी हेभ टु फोकस। Achieving SDGs, that's the part of our slogan. From Cairo Summit ICPD 2, Nairobi Summit ICPD 25, this is all SRHR span. Thank you so much for your listening. Thank you so much for giving this time.
Thank you so much, Dr. Karki. I'm sorry, I'm listening to warn गर्नु पर्यो. I know that we have given in the plan you have 20 minutes तर हामीले कट डाउन गर्नु परेको हुनाले यो स्ट्रेस भएको। अदरवाइज यही रूपले गयो भने हामी फेरि यहाँ 7 बज्ला भन्ने डर भयो हामीलाई। सो फेरि हाम्रो अर्गनाइजरले डिनर पनि हामीलाई खुवाउनु पर्ने हुनसक्छ। त्यसैले चाहिँ हामी अलिक अप्ठ्यारो स्थितिमा गर्नु पर्यो. I can understand that. Thank you so much for your presentation. You have really set up kind of tone for rest of the 6 papers. यो SRHR-को एउटा ल्यान्डस्केप यहाँले प्रेजेन्ट गरिदिनु भयो. त्यसमा चाहिँ अब नेसनल प्लस इन्टरनेसनल पनि यहाँले दिनुभयो. त्यसले चाहिँ रियली इट्स लाइक पाथ अब नेक्स्ट 6वटा पेपरलाई गरेको छ. सो विदाउट एनी डिले हामी अब अर्को प्रेजेन्टरलाई बोलाउन चाहन्छौँ. हामी फेरि माफी माग्न चाहन्छौँ, हामी लामो इन्ट्रोडक्सन गर्नेवाला छैनौँ प्रेजेन्टरलाई. बिकज अफ द टाइम वी हेभ योर बायोग्राफी विथ अस, बट बिकज अफ टाइम हामीले नाम र संस्था मात्रै भन्दैछौँ. राम्रोसँग इन्ट्रोड्युस नगर्यो नभन्नु होला. सो आवर नेक्स्ट प्रेजेन्टर इज हाम्रो मिस्टर विक्रम अधिकारी. उहाँ चाहिँ हर्ड इन्टरनेसनलबाट हुनुहुन्छ र उहाँको पेपरको टाइटल चाहिँ डिकम्पोजिङ इनइक्वालिटी इन नलेज अबाउट HIV प्रिभेन्सन एन्ड डिस्क्रिमिनेटरी attitudes toward people living with HIV among youth aged 15 to 24 years in Nepal. Vikram Adhikari, floor is yours. Tapayko चाहिँ 10 minutes time.
Thank you, chairs. Good evening, everyone. Thank you for providing this wonderful opportunity for allowing me to present my research in this 10th National Summit organized by Nepal Health Research Council. My research topic is decomposing inequality in knowledge about HIV prevention and discriminatory attitude towards people living with HIV among youth aged 15 to 24 years in Nepal. Young people, they are at a higher risk of having HIV due to their risky behaviors. And knowledge about HIV prevention is essential to enable them to avoid HIV infections. The stigma and the discrimination related to HIV, it can hamper the HIV testing, prevention, and care efforts that can affect both people living with HIV and those who are at risk of having HIV. And a study in Ethiopia have shown that the knowledge related to HIV prevention, it is more concentrated towards rich people compared to poor. The inequalities in HIV prevention knowledge and discriminatory attitudes towards people living with HIV, it can ruin the government's effort to reduce HIV stigma. And it can also ruin the government's effort to achieve universal access to HIV care and treatment. In this setting, in order to find what is the situation in context of Nepal, we aim to assess the socioeconomic inequalities in HIV prevention knowledge and discriminatory attitudes towards people living with HIV among youths. And in the next objective of our study is to measure and decompose the inequality differential in HIV prevention knowledge and discriminatory attitudes between different years. Talking about the methodology, we have conducted secondary analysis from Nepal Demographic and Health Survey from 3 consecutive years, 2011, 16, and 2022. In our study, the independent variables involves age, sex, place of residence, ecological belt, ethnicity, religion, marital status, wealth, media exposure, and ever tested for HIV. And our dependent variables include HIV prevention knowledge. It is HIV prevention knowledge and discriminatory attitudes towards people living with HIV. And they are the composite indicators. We have calculated them in a binary form using different multiple questions, creating composite variables. Talking about the statistical analysis, we have performed weighted analysis, and we performed wealth-related inequality using the concentration index and using the concentration curves. And decomposition analysis was carried out using walk-step method. and we applied Osaka Blinder decomposition method in order to measure and decompose the inequality differential between two different time periods. And we use R software and different packages within R for those statistical analysis. And for this statistical analysis, because it is totally new to me, we have explored methods from the several different papers, and we have consulted with some experts and conducted this analysis. Now let's come to the results section. In all 3 consecutive years of NDHS, the male and females, they were distributed in 1:3 ratio. Talking about the age, the distribution was nearly equal between less than 20 years and 20 to 24 years. And now the result part is the knowledge, the proportion of the youth with HIV prevention knowledge, it has decreased from 27.8% in 2011 to 18.8% in 2022. And this decrease in knowledge is seen in both males and females. And on the other hand, the discriminatory attitude towards people living with HIV, it has increased from 37.2 in 2016 to 52.4 in 2022. And this trend is similar in both the males and females. Here, while looking over the distribution of knowledge on HIV prevention and discriminatory attitude towards people living with HIV by wealth quintile, we have seen that in each survey year, there is a substantial gap between richest and poorest wealth quintile group. And if we see over the trend, the proportion of the youth with knowledge on HIV prevention, it has increased from 10.2 in 2011 to 14.6 in 2022. And among the richest, it has decreased from 48.8% to 31.5%. And if we talk about the discriminatory attitude towards PLHIV by wealth quintile, it has decreased in both wealth quintile poorest and richest wealth quintile. And there is a gap between poorest and the richest wealth quintile. And we have plotted the concentration curve. Here, the concentration curve consists of the diagonal line, black color diagonal line. It is a line of the equality. And if the concentration curve lies below the line of equality, then the problem is concentrated towards the richer group. And if the concentration curve lies above the line of equality, then it is more concentrated towards the poor. Here, from the figure, we can see that in 2011, the knowledge on HIV prevention, it is more concentrated in all the years. It is more concentrated towards the. In 2011, the knowledge on HIV prevention, it is more concentrated towards the richer group, whereas the discriminatory attitude, in 2016 and 2022, it is more concentrated towards the poor. And the concentration index for the HIV prevention knowledge has decreased from 0.288 in 2011 to 0.176 in 2022, whereas for discriminatory attitude, it has increased from minus 0.131 in 2016 to minus 0.079 in 2022. It indicates that there is overall reduction in the inequality. And if we see the decomposition analysis of concentration index in NDHS 2022, in both knowledge on HIV prevention and discriminatory attitudes toward people living with HIV, the inequality, the major drivers for the inequality, they are wealth and the education. And if we compare between, if we see from the Osaka Blinder decomposition, if we see the change in inequality, the major contributors for change in inequality in comprehensive knowledge on HIV prevention and discriminatory attitude, the major contributors are same education and the wealth. And for the discriminatory attitude, the type of occupation they are engaged in, that is also the major contributor. And in the conclusion, we have seen that the proportion of youth with HIV prevention knowledge has decreased, while those with the discriminatory attitude has increased. And the inequality in HIV prevention knowledge between 2011 to 22 and discriminatory attitude between 2016 and 2022 among youth has reduced, with the wealth and the education as the major contributing factors. Providing community-based HIV testing and counseling services that incorporate behavior change and HIV prevention communication could be a game changer to enhance knowledge and positive attitude towards people living with HIV. And the government should work collectively with schools and communities to design HIV-related educational interventions for youth and integrate them in the course curriculum. And with this, I'd like to end my presentation, and thank you.
Thank you very much, Bikramji, for completing your presentation in 9 minutes, which is highly commendable. हाम्रो लागि यो प्रेजेन्टेसन देख्दाखेरि चाहिँ अलिक सरप्राइज टाइपको हुनु त डिएचएस हेर्दाखेरि त्यस्तै देखिरहेछ, तर अलिक फरक खालको जो चाहिँ डाक्टर कार्कीले अघि भन्नुभयो, ना वी हेभ टु वरी अबाउट एचआइभी एड्स भने जस्तै प्रिभेन्सनको नलेज घट्ने स्टिग्माको बढ्ने भनेपछि त हामी त रङ डिरेक्सनमा गइरहेको जस्तो देख्यौँ है, झन् बढ्नु हामी त हाम्रो एक्सपेक्टेसन त फरक हो. सो दिस इज काइन्ड अफ अलिक फरक खालको देख्यो र I'm happy to see the decomposition analysis पनि. I think this kind of analysis is rarely done in Nepal. So I would like to really appreciate हाम्रो हर्टको साथीलाई for doing this analysis. Thank you so much. अब हाम्रो नेक्स्ट प्रेजेन्टरलाई बोलाउन चाहन्छु म. नेक्स्ट प्रेजेन्टर हाम्रो जेनी श्रेष्ठ. जेनी श्रेष्ठ चाहिँ अर्ली क्यारियर रिसर्चर हुनुहुन्छ र उहाँले चाहिँ अलि हाम्रोमा पनि लेस रिसर्च भएको एरिया स्पेसली एक्सप्लोरिङ द इन्टरसेक्सन्स अफ डिसेबिलिटी एन्ड एसआरएसआरको सेक्टरमा प्रेजेन्ट गर्दै हुनुहुन्छ. जेनी.
Thank you so much, sir, for the introduction. I will be presenting the study on exploring the intersection of disability and sexual and reproductive health reported needs for women access to care. According to WHO, around 16% of the world population has some form of the disability, and half of them comprises of women. And also, as per the Census Report 2078, 2.2% of the people are living with disability, and almost half of them are women. Only few studies are conducted in Nepal to understand the sexual and reproductive healthcare needs of women living with disability, and the innovative strategies and intervention to address their SRH needs, integrating lived experience and adopting co-designing process are also limited. The study aims to assess the needs of women with disability in accessing sexual and reproductive health services, thereby informing the co-design of intervention to address them. The methodology we have followed is we have used the participated approach to collect the data following a 5-stage human-centered design, which I will be explaining in upcoming slide. And we have focused on life experience of women with physical, hearing, and visual disability. The study sites were Kathmandu, Morang, Dhanusa, and Kanchanpur. The data thus obtained were analyzed thematically. The human-centered design thinking included 5 steps. They are empathize, define, ideate, prototype, and test. Among these 5 steps, the findings that I am sharing today is from empathize session only. In the empathize session, we have collected data from the women with lived experience with the disability and the relevant stakeholders who are working in the sector of sexual and reproductive health and also the disability sector, such as advocates, healthcare providers, FCSV, etc., using participatory method. One of the examples for the participatory method is shown in the figure. In the empathize session, the total number of the participants were a little more than 100 and total 11 sessions were conducted. The results has been summarized in 6 themes, which I will be covering in the upcoming slides. We have included some photos from the research study which we have done with the participants' consent. The first theme is acceptance and recognition of sexual and reproductive health needs by family society, where participants have expressed that there is need of recognition that the woman with disability also can and want to get married, and there is a prevailing perception in the family and society that it will be difficult for women with disability to get married and also to have children. And they have shared that there is general lack of understanding about the diversity within the disability, such as within the physical disability, hearing, and visual impairment. And also they have expressed that this is due to there is no inclusion about the issue of disability in curriculum in schools. There are a few verbatim that we have taken from the research study. I am sharing only one. We are also interested in marriage and sexual relation, but we face judgment from others when we discuss these topics. The second theme is access to information about sexual and reproductive health for women with disability, where the participants have shared that the information regarding sexual and reproductive health are inaccessible in inaccessible format for them. It is more so for hearing disability that they have expressed that it is not available either in online or offline format. And during the sessions also, the hearing disability the women with hearing disability were more curious to express their needs, and they have more confusion and anxiety regarding the sexual and reproductive health terms. They have very basic questions like, if does using pads during the menstruation causes cancer? These were some questions of the women with hearing disability. This may be due to also because there are limited terms regarding sexual and reproductive health within sign language. The third theme is accessible health facility, mainly physical infrastructure. They have shared that there is a limited understanding of disability-friendly infrastructure among the healthcare providers. The understanding is only focused on ramps, and it should be also include the provision of the bed, bathroom, delivery room, and equipments. They have shared that there is a lack of prioritized implementation of related guidelines. One of the participants have shared that sometimes there are doors that wheelchairs cannot pass through, gaps between pathways, and broken roads. There are no clear direction to follow, and even when there are toilets with disabled sign, they may be locked. The fourth theme is respectful care and services at health facility. They have shared that they have experienced judgmental attitude and lack of sensitivity from the healthcare provider, which have resulted in trust issue. And they have also felt that due to unavailability of the support person or the professional sign language interpreters at the healthcare facilities, they feel their privacy is compromised. One of the participants have shared that due to my small height, the doctor at the hospital scolded my sister-in-law for allowing me to get pregnant. They said I shouldn't have gotten married and that it was dangerous for my life to become pregnant. However, after undergoing surgery, I successfully gave birth to baby weighing 300 grams. The fifth theme is safe spaces for women with disability. Here, the participant has shared that the broader understanding of the society towards women in general and also the women with disability have resulted in violence. They have also shared that the existing response system is ineffective to provide justice for the violence survivor. One of the participants have shared, we should also be aware of how to protect ourselves from sexual violence. Understanding this kind of situation can be immensely helpful. Recognizing such behavior of perpetrators and knowing what to do if we find ourselves in such situation is crucial. The sixth theme is communication and navigation support system, where participants have shared that due to the language barrier, they have inability to identify the perpetrator or even communicate about the perpetrators to the concerned body. And due to unavailability of professional health facility, even the health professionals have shared that they have difficulty counseling the women with disability. One of the service provider has shared, in case involving deaf individuals, we face challenge conducting counseling session even with the assistance of their mother. I'll be concluding the study with the take-home message that we have gained after reviewing and discussing the whole study. As I have previously shared, this is the findings from only the empathize session. The take-home messages are, participants with lived experience offer valuable insight that help to comprehend the nuances of existing gaps. Coordinated efforts to create safe and respectful care for women with disability is beyond sensitization, and creating awareness is required. The next step after the finding is we will be identifying the potential solutions to the identified needs and barriers, and also developing an intervention which will be tested in another research study. Finally, I would like to acknowledge the research participants, stakeholders, sign language interpreter, captioners, Nepal Disabled Women Association, Nepal Health Research Council for supporting us throughout the research. Thank you.
Thank you very much, Jenny for really digging out the situation of disabled people in Nepal, which is one of the neglected area always. We all talk about leaving no behind, inclusiveness. Despite that, I think we are living all this kind of innovative kind of research. And then thank you for contributing, actually adding some more informations in this area. त्यति भनेपछि now I would like to request हाम्रो अर्को प्रेजेन्टरलाई समयलाई ध्यानमा राखेर कृति लामिछाने, I think she is from IPAS हुनुहुन्छ र उहाँले चाहिँ she is going to talk about the relationship, association between knowledge about safe abortion and then use of contraceptions. Is there any link? कृति जी.
Hi, namaste and good afternoon everyone. Thank you, chairs. Before starting my presentation, I'd like to thank NHRC for providing this wonderful learning sharing platform. So today I'm going to present our findings of the research done in 2022 with the ethical approval from Nepal Health Research Council. The topic of my presentation is exploring the association between knowledge of safe abortion and contraceptive uses among married women of reproductive age, that is 15 to 49 years, from a national survey, insights from a national survey in Nepal. So I'll also like to thank my co-authors, research participants and stakeholders. The objective of our research was to explore the association between knowledge of abortion legality and its conditions with contraceptive use among WRA. So Abortion is considered a safe health procedure according to WHO and has been legalized in Nepal since 2002 AD. Our Nepal's law allows abortion with pregnant women's consent for up to 12 weeks and up to 28 weeks if certain conditions are made, such as threats to the woman's life, physical or mental health, fetal anomalies, and rape. Even after having such progressive abortion law, Nepal still more than 57 abortions happening in Nepal are unsafe. And a notable percentage of women, that is 21%, have unmet family planning needs. And about 62% of pregnancies ending in abortions are unwanted and 25% are mistimed. So promoting contraception and safe abortion awareness is undeniably crucial to avoid unintended pregnancy and to prevent unwanted complications. So for our research, we did quantitative research approach with descriptive cross-sectional research design. So this is a snapshot of our study sites. For our study site, 2 districts, each from 7 provinces, were selected. Districts having the highest and second highest abortion case proportion were selected. Additionally, we also selected Kathmandu and Lalitpur from the Kathmandu Valley to capture data from the federal level. From young adults from the age group 25 to 29 years of age. The majority of participants were Janajati. Most of our participants have never attended school, and most of them were not working at the time of the study. So the majority were from richer wealth quintile, and more than half of the participants, that were 55.7%, were affiliated to a saving and credit group. So now moving on to the percentage distribution of ever married contraception user. Looking at the graph, we can say that the age was statistically significant, with the adolescents being the ones with the least number of contraceptive users, and the age group of 30 to 34 years being the highest user. Ethnicity was also statistically significant, with Dalit being with Muslim and Madhesi being the least user. In education, this is quite interesting that with increase in education, we're seeing the decline in use of contraception. This may be because of the perceived side effects that comes with the education that some studies have shown. And marital status, currently married women were using the contraception more than the single women. And in occupation, skilled servicers were using the contraception more, while students were the least contraceptive user. So in our multivariate analysis, we've seen that the respondents with abortion legality knowledge were 1.52 times more likely to use contraception than compared to the one who did not knew about the abortion legality. Whereas in respondents with abortion legality condition knowledge, they were 2 times more likely to use the contraception as compared to the one who were not known to the abortion legality condition. So to conclude, the results highlight that simply having a formal education isn't enough to promote contraceptive use. Prioritizing government-led awareness campaigns and providing contraceptive counseling through healthcare providers is essential. Those efforts can disperse myths about contraception side effects and encourage its use. It is also crucial to tailor contraceptive initiatives to meet the unique needs of younger women, those from low-income households, those with stronger cultural ties, and those who are unemployed. And with these strategies, it will surely contribute the government target of achieving a 60% usage rate of modern contraception methods by 2030. So, lastly, the key takeaway is that abortion should not be viewed as an alternative of contraception. Raising education on safe abortion services can have a positive impact on increasing contraceptive uses. This will contribute to reduce unintended pregnancies and ultimately lower the rate of induced abortions. So to effectively address these issues, it is recommended that policymakers implement targeted strategies focusing on a specific groups of women who really need the awareness on both abortion legality and contraception use. Thank you.
Thank you so much, Kirti.
And these are my references used in this presentation.
Thank you so much for your presentations. I mean, you also have contributed in new evidence. It's frustrating to say from this forum is like in 2022 DHS doesn't ask about abortion knowledge and legality, which is a clear missed an opportunity. I don't know why they missed it. This is a missed opportunity. हाम्रो Dr. खेमले पनि कुरा रेज गर्नुभयो जब गभर्नमेन्टको प्रोग्राम छ DHS जस्तोमा 2016 मा थियो 22 मा मिस गरेको छौं. Somehow IPAS को यो स्टडीले at least they have this information, knowledge about abortion legality, so that some kind of gap, information gap like fill garcha. As a researcher, abortion is a very core of my heart. I spent like 20 years. I have number of comments and concern, Kriti, on your analysis, which we can discuss later on. We don't have a time now, but I see the area why we are having that kind of relationship, and what are the other measures we have to control to look at the relationship between contraceptive use and abortion legality. And for example, what is the rationale for just using one legality conditions knowledge? Why not 3? Why 2? Why not 5? You know, those kind of things we can discuss. Anyway, thank you so much for this. At least we have some more information in this area. अब म अर्को हाम्रो प्रेजेन्टरलाई बोलाउन चाहन्छु जो चाहिँ नस्ना महर्जन हुनुहुन्छ। नस्नाले चाहिँ स्लाइटली डिफरेन्ट टपिकमा प्रेजेन्ट गर्दै हुनुहुन्छ। उहाँको टपिक चाहिँ इफेक्टिभनेस एन्ड इम्प्लिमेन्टेसन अफ सिमुलेसन बेस्ड मेन्टरसिप प्रोग्रामको विषयमा चाहिँ उहाँले प्रेजेन्ट गर्दै हुनुहुन्छ। नस्नाजी।
Thank you so much, respected chairs. Namaste and a very good afternoon to you all. One Heart Worldwide recently piloted a simulation-based mentorship program in 4 districts of Nepal, and today I'm presenting the results of the program evaluation. Here are the names of the authors. Okay, these are the study districts. We piloted the program in 4 districts, Magdi, Dolakha, Sarlahi, and Udaipur in 2 phases. During the implementation of simulation-based mentorship program, first of all, we developed a learning resource package. Then 10 master trainers were trained. After that, 56 program sites were selected. Under the program sites, we had 14 hub birthing centers and 32 sub-hub birthing centers. After that, district level local mentors were trained. Similarly, we also set up a simulation lab at the 14 hub sites. Following that, we conducted monthly mentoring sessions on 6 topics, 6 sessions, 1 session every month, followed by 4 weekly practice sessions. Here are the names of the monthly sessions and the session duration. Infection prevention, ANC and PNC modules were combined in 1 session. ECLB, essential care of labor and birth, helping babies breathe, bleeding after birth, and pre-eclampsia and eclampsia. We selected the birthing centers with high number of deliveries, having more than 60 annual deliveries. Similarly, those birthing centers with space for simulation lab establishment and availability of mentors were selected as the hub sites. Here is the picture of one of our simulation lab from the hub site. These are some of the teaching and learning methodologies that we used in our study, in our program. On the left-hand side, you can see the simulation of postpartum hemorrhage management, and on the right-hand side, you can see the action cards that we used in our program. Okay, that was a very brief presentation about the program. The research was conducted using an implementation research framework to assess the reach, effectiveness, adoption, implementation, and maintenance of simulation-based mentorship program. These are the re-aim dimensions in the study. Under the effectiveness dimension, we assess the changes in knowledge and skills of the nurses. Likewise, under the implementation dimension, we assess the implementation fidelity, and the perception regarding maintenance and continuation of program was assessed under the maintenance dimension. Moving on to the methodology, as I mentioned before, this was an implementation research using a mixed method approach. The study design was quasi-experimental. Out of the 112 birthing centers, half of them, that is 56, were categorized as the intervention birthing centers, and half were categorized into the control birthing center. And midline assessment were conducted immediately following the completion of the intervention, whereas inline assessments were done 6 months after the intervention. Today, I'm presenting the inline findings. The participants were selected purposively. They were the nurses and ANMs working in birthing centers of the selected health facilities. Likewise, we also conducted 58 in-depth interviews with mentors, mentees, our staff, and local level stakeholders. These are the data collection tools that we used. The knowledge assessment was done in both intervention and control group participants, but the skills assessment was done among the intervention group participants only. We took approvals from NHRC. Data analysis was done in Stata and NVivo. We also conducted program at the control sites after completion of the intervention. Moving on to the findings. Okay, these are the characteristics of our study participants. Most of them were from A&M background. This slide shows the reach. We trained 34 local level mentors, and all of them completed the 7 days district level mentor development training. However, only 75% of the mentees or the intervention group participants, they received monthly sessions on all the 7 modules. Regarding the weekly practice, the participation rate ranged from about 65% to about 75%. We included both SBA and non-SBA in our program, and that was really appreciated. However, we were also suggested to include paramedics, doctors, new or transferred nursing staff, and also the office helpers during our program, especially in the infection prevention module. This table shows the effectiveness. The skills assessment was done among the mentees. As you can see from the table, the baseline score, compared to the baseline score, the inline score are statistically significantly higher. Overall, the difference was 50.3% between the inline and baseline comparisons. Likewise, as I mentioned before, knowledge assessment was done among the control group as well. We used difference and difference analysis. Similar to the skills assessment findings, all the module, the scores were more among the intervention group participants in all the modules. The difference in difference analysis shows that there was around 14.6% adjusted difference between the scores obtained by the intervention and control group participants. Okay, these were the reasons behind the increased effectiveness mentioned by our participants. They mentioned that SPMP was helpful in increasing the confidence. They were able to provide respectful care. Timely referral, health facility readiness was improved. Likewise, they made quicker diagnosis, and there was better teamwork after SPMP. And this, in turn, led to improved health service delivery and better case management in their respective health facilities. However, there were some implementation level challenges. When we planned the program, it was supposed to be, the average duration between 2 monthly sessions was supposed to be 1 month only, but it was 55% overall. 55 days, sorry. We asked about the program components as well. The in-depth interview participants, especially the mentees, they liked the program components, especially the use of mannequins and the low-dose, high-frequency approach that we used. The main challenge that we faced was the dropout of mentors and mentees in our program, and it was mostly due to voluntary resignation or termination of the staff, termination of the contract of the staff, and transfer to other health facilities. This led to certain difficulties during our program implementation. Our program staff felt difficulty in mentors mobilization. Similarly, there were certain challenges in scheduling the sessions and delays in conducting the monthly sessions as well. Other challenges include time management, weather extremes, and COVID pandemic. We asked the stakeholders regarding the continuation of the program, and there was a strong consensus among the stakeholders, mentors, and mentees that the program must continue. The cost of continuing SBMP by the local government is, for 1 monthly session is around rupees 10,000, and per 6 monthly session is around rupees 60,000. The cost of SBMP training per mentee per session is around rupees 3,000. Regarding the perception about continuation, the in-depth interview participants mentioned that SPMP aligns with other M and H related priorities at their local level, but they needed additional guidance and requested for additional orientation and support in planning and implementation. They also feared the difficulties due to lack of finances, staff shortage, and high caseload. Moving forward, simulation-based mentorship program was effective in improving not just improving but also retaining the knowledge and skills of the nurses and ANMs working in different birthing centers of 4 districts of Nepal. So simulation-based low-dose high-frequency approach. We used low-dose high-frequency approach in our program. This approach could be a valid alternative for training eminent service provider of the country to provide perinatal care. Similarly, simulation-based methodology can be integrated in different in-service and pre-service trainings of our country. Thank you so much.
Thank you so much, Nasaji, for your different but very important presentations. We know that the mental safe and training and follow-up definitely improves the outcome. We know that, त्यसलाई फर्दर एभिडेन्सहरू दिएको छ तर एज मैले हेर्दाखेरि धेरै राम्रो कुराहरू यसमा छन् रिसर्चर्स भएको आँखाले चाहिँ नेगेटिभमा पहिला जाँदो रहेछ कि आँखा है मेरो त्यो बानी सुधार्न खोज्दा सुधार्न सकिरहेको छैन मैले तर देयर आर सर्टेन लाइक अब प्रेजेन्टरले प्रेजेन्ट गर्दाखेरि मैले फाइन्डिङ्स हेर्दा नि मेथड्स एनालाइसिस हेर्ने हुनाले क्वालमा चाहिँ पर्सेन्टेज मजाले प्रेजेन्ट गर्नुभएको छ उता डिआइडी गर्नुभएको छ विच इज भेरी हाई लेभल स्ट्याटिकल एनालाइसिस यस्तो खालको डेटालाई आई सी भेरी गुड थिङ देयर एज वेल एट द सेम टाइम कस्तो खालको कन्ट्रास्टिङ प्रेजेन्ट गर्नुभएको छ कि यु हेभ क्वान्टिटेटिभ एनालाइसिस साउन्ड युजिङ डिआइडी and at the same time we are also presenting qualitative data which has a percentage distribution as well. And then I only read your findings. The findings, yes, we know that this is helpful, mentorship is needed, can be integrated, त्यसलाई अलिकति अब योलाई नेक्स्ट स्टेपमा हजुरले जान्छ त्यो अलिक विचार गर्नुपर्छ जस्तो लाग्छ मलाई एनालिटिकल फ्रेमवर्कमा कुरा गर्दाखेरि चाहिँ बट नो डाउट डेफिनेटली इज युजफुल स्टडी अब नेक्स्ट प्रेजेन्टर हाम्रो प्रियङ्का तिमसेनाजीले प्रेजेन्ट गर्दै हुनुहुन्छ उहाँले चाहिँ इफेक्टिभनेस अफ सर्भाइकल क्यान्सर स्टिग्मा रिडक्सन इन्टरभेन्सनको बारेमा प्रेजेन्ट गर्दै हुनुहुन्छ प्रियङ्काजी उहाँ चाहिँ एपाथ ब्रेस्ट एन्ड सर्भाइकल क्यान्सर प्रोग्रामबाट हुनुहुन्छ
Good evening, everyone. Today, I'll be presenting a study titled Effectiveness of Cervical Cancer Stigma Reduction Intervention on Cancer Stigma Score and Cervical Cancer Screening Uptake in Nepal. These are the list of authors. In 2020, about 90% of the cervical cancer cases were seen in low and middle income countries. Cervical cancer is the 4th most common cancer among women globally. In Nepal, it is the 2nd most common cancer among women. Despite being preventable through HPV vaccination, screening, and treatment, its burden is quite high, which is due to low access to these preventive measures, lack of knowledge, and stigma. There are several stigma prevalent for cervical cancer, which leads to low screening uptake, high treatment dropout, and low quality of life. There are several educational interventions done in different fields to reduce stigma. However, they are insufficient. So studies done in the field of mental health and HIV have shown a combination approach using parasocial contact, educational and participatory approach effective in reducing stigma. Despite prioritization of screening in several national guidelines and programs, the screening coverage is very low in Nepal, which is just about 8.2%. Studies have shown that cervical cancer stigma is negatively associated with screening. So the findings from this study can help stakeholders in developing programs to increase cervical cancer screening uptake. The objective of this study is to assess the effectiveness of stigma reduction intervention on cancer stigma score and cervical cancer screening uptake in Nepal. This is an intervention study where simple randomization was done using STATA 14, where 12 wards were randomized in allocation ratio 1:1. So there were 6 wards in each arm with cluster size 25. So the study site was Buranilkantha municipality. There were 13 wards in Buranilkantha municipality, and we excluded Ward 3 because there was an ongoing cervical cancer screening program there, and most of the women in that ward were screened. The study population is women aged 30 to 60 years. The inclusion criteria is married women, residents, and women who had not undergone cervical cancer screening in 5 years. The exclusion criteria is women with hearing or mental disorders, pregnant women, women less than 6 weeks postpartum, and women who are already diagnosed with cervical cancer, pre-cancer, and have undergone hysterectomy. The sample size was calculated taking a reference from a study done in Dhulikhel municipality where the mean stigma score was 2.6. So assuming a 10% reduction in the intervention group after our intervention, the sample size was found to be 155 in each arm. So the participants were recruited through FCHVs and elected female ward representatives, where we contacted the interested women, and after accessing their eligibility criteria and taking their informed consent, we recruited them in our study. We conducted a baseline and then we did the intervention. We took a deliberate gap of 2 months after the intervention because studies have shown that stigma reduction intervention had shown weaker effect over longer period of time. Our study was tied up with a VIA camp done by Buranilkantha municipality where we made phone calls to women in both intervention and control group to join the screening program. So screening uptake data was taken from the camp data. Our intervention was guided by stigma mechanism in health disparity framework, which mostly targets public stigma, majorly across 3 levels, that is sociocultural, interpersonal, and individual. All these 3 levels of stigma directly affects health behavior, which in our case was screening uptake. So we did a 1-day 4-hour session involving 12 participants from each ward. To give them knowledge and facts on cervical cancer, we did a presentation where we told them about its burden, signs and symptoms, preventive measures, financial determinants, and treatment services. We also showed them a video of cervical cancer survivor where she narrates her own life experiences. So that helped women to personalize this information, relating it to their own life experiences and thus changing their attitude and behavior. We also conducted group discussions among women where they discussed on the drivers, facilitators, types, and consequences of stigma prevalent in the community. This helped enhance social networks, social interaction, and social support. At last, we also showed them a myth versus fact flashcard, which was used to correct myths and misconceptions on cervical cancer and provide them the factual information. In the baseline, we collected data on cancer stigma and socio-demographic variables, and in the end line, we collected data on cancer stigma and screening uptake. The data collection tools was cancer stigma scale, which is a 6-point Likert scale having 25 items. So the mean stigma score more than 3 was considered as stigma. There are 6 domains in this scale: severity, awkwardness, avoidance, personal responsibility, policy opposition, and financial discrimination. The tool is a validated tool in Nepal. Frequencies and percentage were calculated for data analysis in categorical variables, and means and standard deviation for continuous variables. So as we took cluster as our sampling unit, we thought that the outcomes would be correlated. So we used generalized estimating equations with logistic regression, where intervention status was the independent variable, and cancer stigma and screening uptake was the outcome variable. So this is the consort flow diagram where we allocated 6 wards in the intervention groups and 6 wards in the control group. Out of 156 participants in the intervention group, 43 declined our intervention. We conducted a follow-up after 2 months, and some participants were lost to follow-up both in the intervention and control group. However, it was not much of a problem in our study because we had already taken 20% loss to follow-up for calculating the sample size. So we did our analysis by intent to treat principle. The prevalence of stigma was quite similar during the baseline, which was about 26% in both the groups. However, in the end line, the stigma in the control group was 13%, and in the intervention group it was 4%. So the 9% reduction in stigma was because of our intervention. There were no significant differences found in the socio-demographic variables in the intervention and control group. However, a significant difference was found in age, where mean age of participant in the intervention group was 40 and control group was 42 years. The odds of having overall stigma was 0.25 times lower in the intervention group as compared to the control group. The odds of having stigma in the severity domain was 0.31 times lower in the intervention group as compared to the control group. And the odds of having stigma in the awkwardness domain was 0.21 times lower in the intervention as compared to the control group. No significant differences were found in other subdomains like personal responsibility, avoidance, and financial discrimination. The odds of having cervical cancer screening uptake was 3.9 times higher in the intervention as compared to the control group. The strength of the study was, this is the first study to assess the effectiveness of cervical cancer stigma reduction intervention in reducing stigma and assessing its effectiveness in screening uptake. We used a validated tool in Nepal with Cornback alpha 0.85. The limitations are festivals, elections were responsible for loss to follow-up of participants. Voluntary participation was there in each cluster, which may not be a representative of the population. We could not measure the change in stigma in long run, which might directly affect the screening uptake. So, cervical cancer stigma reduction intervention is effective in reducing cancer stigma among women aged 30 to 60 years in Nepal. It is also effective in increasing cervical cancer screening uptake in Nepal. So, this stigma reduction intervention should be scaled up in low and middle income countries to increase the cervical cancer screening rates. We did this study in Buranilkantha municipality, which is an urban municipality in Nepal. So, its effectiveness is to be further tested in the rural areas of Nepal. Thank you very much.
Thank you so much, Priyanka-ji. I think this is one of the study I like. I think you have used proper design despite them, and then also the analysis you have used. I think Z you have used, which is perfectly matches for this kind of data. So, मलाई त्यो मन पर्यो तर of course recommendation मा scale up हैन कुराहरुमा चाहिँ we can discuss. अब मलाई थाहा छ हाम्रो सहभागी साथीहरु lot of questions होला, so we will take that questions later on. तर I think this is one of the well done study जस्तो लाग्यो मलाई stigma related भए पनि in terms of design and in terms of analysis कुरा गरेको मैले चाहिँ. Okay, so next presentation चाहिँ हाम्रो Professor Dr. Bhimsen Devkota सरको छ. उहाँ चाहिँ प्रोफेसर हुनुहुन्छ हेल्थ एजुकेसनमा त्रिभुवन युनिभर्सिटीमा र उहाँ मेरो साथी पनि हो. भीमसेन सर, तपाईलाई फोन.
Respected chairs and audiences, अब यो प्रेजेन्टेसन चाहिँ मेरो प्रिन्सिपल इन्भेस्टिगेटरले प्रेजेन्ट गर्ने भनेर स्लाइडहरू उहाँले बनाउनु भएको थियो. हावामै हुनुहुन्छ, आउँदै हुनुहुन्छ, तर आइपुग्नु भएन. त्यस कारणले एज पार्ट अफ द क्राइसिस म्यानेजमेन्ट मैले चाहिँ अन बिहाफ अफ हर टिम हैन एज ए को आई चाहिँ मैले चाहिँ प्रेजेन्ट गर्छु. यसमा चाहिँ सारा वुमेन यो पिट्सबर्ग युनिभर्सिटी युएसए को हुनुहुन्छ पिआई, अनि यसमा इन्क्लुडिङ मी हामी 5-7 जना छौँ र प्लस अब यो लोकल गभर्नमेन्टसित पनि चाहिँ कोल्याबोरेसन गरेर गरेको सानो एउटा पाइलट स्टडी, वास्तवमा क्वालिटेटिभ स्टडी इभेन्ट सेन्टर डिजाइनमा बेस गरेको. त्यसको बेसिसमा अलिकति लार्ज स्केलको चाहिँ इन्टरभेन्सन गर्न सकिन्छ कि भनेर यो गरिएको थियो. एनएचआरसीबाट इथिकल एप्रुभल लिएरै गरेको स्टडी हो यो 2023 मा. अब यो चाहिँ खास गरिकन यो मेन्सुरल सेक्लुजनमा अब मिड अफ फार वेस्टको जुन छौपडीलाई नै फोकस गरेर गरेका थियौँ हामीले यो पाइलट चाहिँ. सरेर त योबाट त एरोमै हानेको त्यो अर्को ल्याउनु त
काम गरेन
ए यहाँ छ अब यो छोपडीमा धेरै इन्टरभेन्सन कार्यक्रमहरू भएका छन् हैन अब मेन्सुरल रेस्ट्रिक्सन स्टिगमा त देशैभरि छ तपाईँ हाम्रो घरमा पनि छ तर हैन एकदम प्रोमिनेन्टली चाहिँ हामी चाहिँ सुदूरपश्चिम कर्णाली प्रदेशमा चाहिँ आँखा लगाउँछौँ जहिले पनि र त्यहाँ पनि धेरै चाहिँ प्रोग्रामहरू भएका छन् अब ल पनि आइसक्यो क्रिमिनलाइजेसन ल 2017 मा डिस्पाइट द्याट चाहिँ डिफ्रेन्ट फर्ममा चाहिँ हैन मेन्सुरल रेस्ट्रिक्सनहरू स्टिग्माहरू स्टिल एक्जिस्ट है त्यसकारणले गर्दाखेरिमा अब केले काम गर्छ त व्हाट वर्क्स वेल भन्ने हिसाबले चाहिँ वास्तवमा एउटा पोजिटिभ पोइन्ट अफ भ्यूबाट चाहिँ अब हेरौँ र त्यो प्रोसेसमा चाहिँ त्यहाँको इम्पोर्टेन्ट स्टेक होल्डरहरू आफै इन्भल्भ भएर केही इन्टरभेन्सनहरू डिजाइन गर्यो भनेदेखि त्यसको चाहिँ एउटा ल्यास्टिङ खालको चाहिँ केही चेन्जेसहरू देख्न सकिन्छ कि भनेर यो खालको चाहिँ डिजाइन गरिएको थियो हैन अब यसमा चाहिँ खास गरिकन यो ह्युमन सेन्टर डिजाइन युज गर्न गरिएको थियो हामीले थ्याङ्क यू जेनीजी तपाईँको प्रेजेन्टेसनमा नि त्यसको अलिकति प्रोसेसहरू तपाईँले ल्याइदिनु भयो हैन अब हाम्रो चाहिँ मेन हाइपोथेसिस के थियो भनेदेखि यस्तो कुनै एउटा त्यस्तो टुल डेभलप अथवा प्रोसेस मेथोलोजी डेभलप गर्न सकियोस् ताकि हामी चाहिँ त्यसमा चाहिँ सम्बन्धित स्टेक होल्डरहरूलाई नै युज गरेर त्यसको एउटा चाहिँ मिनिङफुल चाहिँ वेजहरू चाहिँ डिजाइन गर्न सकियोस् भन्ने खालको चाहिँ यसको चाहिँ इन्टेन्सन थियो यो स्टडीको अब यसलाई मैले धेरै भन्न चाहिनँ यो चाहिँ वास्तवमा चाहिँ यो सुरुमा चाहिँ प्राइभेट सेक्टरहरूले युज गरेको डिजाइन रहेछ यो बिस्तारै यो चाहिँ पब्लिक हेल्थमा पनि यसको प्रयोग हुँदै गइराखेको छ र विभिन्न देशहरूमा चाहिँ यसको प्रयोग अहिले भइराखेको छ इन्क्लुडिङ नेपाल हैन अब यसको चाहिँ मेन ऱ्यासनल चाहिँ के हो भनेदेखि हामीले चाहिँ कम्युनिटी मेम्बर्सलाई एन्ड युजरहरूलाई नै कुनै इन्टरभेन्सनमा एक्टिभ पार्टिसिपेसन एज एक्सपर्ट उनीहरूलाई नै एक्सपर्टको रूपमा युज गर्न सकियो भनेदेखि उनीहरूको भोइसलाई चाहिँ हामीले चाहिँ ध्यान दिन सकियो भनेदेखि एउटा इफेक्टिभ र सस्टेनेबल खालको चेन्ज ल्याउन सकिन्छ भन्ने खालको मान्यता राख्दो रहेछ यसले अब यस अन्तर्गत चाहिँ हामीले चाहिँ अब यो हिस्ट्री अलिकति यो कुन देशमा के स्टडी चाहिँ गरेको थियो ह्युमन सेन्टर डिजाइनमा भन्ने छ यसमा मैले यसमा गइनँ धेरै खास गरिकन यो अफ्रिकन कन्टिनेन्टमा यसको धेरै युजहरू भएको देखिन्छ लिटरेचरहरू हेर्दाखेरिमा र अब यो चाहिँ वास्तवमा एकदम मैले अघि नै भने अब छोटो वर्कसप गरेर हामीले चाहिँ डिफ्रेन्ट स्टेक होल्डरसित चाहिँ डिफ्रेन्ट चाहिँ फेजमा इन्टरेक्सन गरेर अनि त्यसको बेसिसमा उहाँहरूकै रिकमेन्डेसनको आधारमा एउटा सानो इन्टरभेन्सन बनाएर त्यसलाई पाइलोटिङ गरिएको हो यसमा चाहिँ त्यसो भएको हुनाले जम्मा 6वटा चाहिँ यो ह्युमन सेन्टर डिजाइन एक्टिभिटीहरू गरिएको थियो त्यसको लागि चाहिँ 4 दिने वर्कसप गरिएको थियो यो स्टडी चाहिँ दैलेख जिल्लाको यो भैरवी गाउँपालिकाको यो रावतकोट भन्ने ठाउँमा त्यो कम्युनिटीमा चाहिँ गरिएको थियो यो स्टडी अहिले मैले भन्न बिर्सिछु त्यसलाई र अनि यसको लागि चाहिँ त्यो वर्कसपको साथसाथै चाहिँ एउटा कम्युनिटी डिजाइन टिम भनेर त्यो इन्टरभेन्सन डिजाइन गर्नलाई 10 जना चाहिँ पार्टिसिपेन्टहरू त्यो कम्युनिटीले नै छानेको र त्यसमा चाहिँ 20 to 59 इयर्सका पार्टिसिपेन्टहरू हुनुहुन्थ्यो जसले चाहिँ छोपडी प्र्याक्टिस गरिराखेको अब त्यसपछि डिफ्रेन्ट कास्ट इथनिक सोसियो डेमोग्राफिक ब्याकग्राउन्डको हुनुहुन्थ्यो उहाँहरू र त्यसको अतिरिक्त अर्को एउटा चाहिँ त्यो टिमले बनाएको चाहिँ फाइन्डिङहरूलाई भ्यालिडेट गर्नको लागि चाहिँ अर्को एउटा कम्युनिटी भ्यालिडेसन टिम भन्ने थियो त्यसमा पनि 12 जना चाहिँ पार्टिसिपेन्टहरू सेलेक्सन गर्नुभएको थियो जसको एज रेन्ज चाहिँ 27 देखि 62 वर्षको थियो त्यसमा चाहिँ मेन वुमेन हैन इन्क्लुडिङ चाहिँ रिलिजियस लिडर्सहरू पनि हुनुहुन्थ्यो त्यसमा चाहिँ अब यो ह्युमन सेन्टर डिजाइनको वास्तवमा चाहिँ 2-3टा फेज हुँदो रहेछ यसमा पहिला चाहिँ हामी यो डिस्कभरी फेज भन्छौँ त्यसमा चाहिँ 3-4वटा एक्टिभिटीहरू गरिँदो रहेछ एउटा चाहिँ हामीले स्टेक होल्डर म्यापिङ गऱ्यौँ सुरुमा त्यहाँ चाहिँ को हो त हु आर द की पिपुल हैन हु आर इन्फ्लुएन्सियल इन एड्रेसिङ द छपडी इस्यु भनेर अनि त्यसपछि दोस्रोमा चाहिँ वाक अ माइल इमर्सन भनेर त्यो अलिकति चाहिँ त्यस्तो भएको स्पटहरुमा हाउसहोल्डहरुमा जाने हैन विथ कम्युनिटी पिपल छलफलहरु गर्ने कुराहरु भयो। तेस्रोमा चाहिँ एक्सपिरियन्स डायग्रामिङ भनेर त्यो के एक्सपिरियन्स भयो त त्यो हेरेर आइसकेपछि भएर फेरि उहाँहरु बसेर वर्कसपमा त्यसलाई चाहिँ एउटा डकुमेन्टेसन गर्ने काम हुँदो रहेछ। अनि त्यस पछाडीको फेजमा चाहिँ यो डिजाइन फेज भनेर त्यसमा चाहिँ टुल्स डिजाइन खास गरिकन यो के क्रिएटिभ एक्टिभिटीहरु इन्टरभेन्सनहरु गर्न सकिन्छ त्यसको चाहिँ म्याट्रिक्स बनाउने, त्यसपछि गएर त्यसलाई भिजुअलाइज गर्ने र अनि मोस्ट सिग्निफिकेन्ट चाहिँ इन्टरभेन्सनहरु जुन उहाँहरूले छलफलबाट बनाउनुहुन्छ त्यो मध्ये कुनै 3टा अथवा 4वटा इम्पोर्टेन्ट चाहिँ इन्टरभेन्सनहरुलाई फेरि भोटिङ गरेर एउटा खालको डेमोक्रेटिक एक्सरसाइजबाट फेरि र्याङ्किङ गर्ने कामहरु हुन्छ त्यसमा चाहिँ हैन। अनि त्यसपछि अनि 6औं स्टेजमा गएपछि चाहिँ त्यो पोस्टरहरु चाहिँ उहाँहरूले आफ्नो खालको हिसाबले चाहिँ म्याट्रिक्सहरु पोस्टरहरु विभिन्न खालको मेटेरियल्सहरु डिजाइन गर्नुहुन्छ र अनि त्यो गरेको दुईटै त्यो फर्स्ट फेजमा पनि सेकेन्ड फेजमा पनि अघि मैले भनेको जुन हाम्रो कम्युनिटी चाहिँ भ्यालिडेसन ग्रुप छ त्यो ग्रुपले चाहिँ फेरि त्यो फाइन्डिङहरु चाहिँ उहाँहरुसँग बसेर शेयर गरेपछि अनि दुईटै स्टेजमा टुल बनाउँदाखेरिमा पनि त्यो निड्सहरु आइडेन्टिफिकेसन गर्दाखेरिमा पनि र इन्टरभेन्सन डिजाइन गर्दाखेरिमा पनि त्यो भ्यालिडेसन गरिएको छ यो प्रोसेसमा चाहिँ। अब यिनै कुराहरु हो, मैले यसलाई भनिराखिन किनभनेदेखि अघि चाहिँ डायग्राममा देखाएकै कुराहरु छन् यसमा। यो जस्तो त्यहाँ गरेको एक्टिभिटीहरु चाहिँ त्यहाँ देखाइएको छ त्यो चित्रहरुमा त्यो फोटोहरुमा। अब त्यो भ्यालिडेसन मिटिङमा चाहिँ खास गरिकन चाहिँ यो डिफरेन्ट अघि भनेकै चाहिँ स्टेक होल्डरहरुलाई चाहिँ उहाँहरुको फिडब्याक कलेक्सन गर्ने, उहाँहरुको चाहिँ भोइसेसहरुलाई चाहिँ त्यो स्पेस दिने कामहरु र त्यसलाई चाहिँ एउटा भोटिङ गर्ने र एउटा कन्सेन्ससमा पुग्ने कामहरु गरिएको छ। अब फाइन्डिङ चाहिँ के छ भने सानो क्वालिटेटिभ पाइलट स्टडी भएको हुनाले यसको फाइन्डिङ त्यस्तो लार्ज स्केलको चाहिँ तपाईको चाहिँ जेनरलाइजेबल त छैन। तैपनि एउटा के हुँदो रहेछ भने यो चाहिँ विथ द वान अफ द बेस्ट वेज अफ हाउ वी क्यान हैन मोटिभेट पिपुल टु पार्टिसिपेट इन कम्युनिटी इन्टरभेन्सन डिजाइनिङ भन्ने कुराहरु चाहिँ आएको छ र खास गरिकन उनीहरुको चाहिँ यो एक खालको इम्बोडिड एक खालको चाहिँ एकदम इनहेरिएन्ट खालको पार्टिसिपेसन भोइसहरु चाहिँ रेज गर्ने चाहिँ यसले चाहिँ स्पेस दिँदो रहेछ भन्ने कुराहरु आयो। अब यहाँ केही कोटेसनहरु छन् उनीहरुको चाहिँ अलिकति आफू कसरी इम्पावर भयो यो थ्रु आउट दिस प्रोसेस भन्ने कुराहरु आएको छ यसमा हैन। र खास गरिकन उहाँहरु चाहिँ दे वर सो मच एक्साइटेड टु पार्टिसिपेट एन्ड टु डिजाइन देमसेल्फ हैन the most feasible kind of interventions. त्यस्तै गरेर यसमा चाहिँ यो फिमेल कम्युनिटी हेल्थ भोलिन्टियरहरु अनि त्यो डिजाइनको कुराहरुमा बडा आएको कुराहरु हो। यो चाहिँ त्यो डिजाइन गर्दाखेरिमा अब कुन टार्गेट ग्रुपले लाई के गर्न सकिन्छ भन्ने हिसाबले डिजाइन गर्नुभयो उहाँहरुले। जस्तो फिमेल कम्युनिटी हेल्थ भोलिन्टियरको लागि चाहिँ कसरी रोल मोडेल हुन सकिन्छ, मदर्सहरुको इन्टरभेन्सन, कम्युनिटीको लेभलको इन्टरभेन्सन अनि त्यस्तै गरेर फादर्सहरुको लागि हैन एडोलेसेन्टहरुको लागि यसरी डिफरेन्ट टार्गेट ग्रुप छुट्याएर उहाँहरुले चाहिँ त्यो सानो सानो एक्टिभिटीहरु चाहिँ डिजाइन गर्नु भएको थियो। अब हाम्रो कन्क्लुजन चाहिँ के छ भन्देखि अब यो चाहिँ इट्स अ काइन्ड अफ क्रिएटिभ एन्ड मोर इन्गेजिङ प्रोसेस है र त्यसले चाहिँ एक खालको इम्पावरमेन्ट पनि उहाँलाई इन्टरनल रियलाइजेसन पनि गर्दो रहेछ त्यो प्रोसेस वेयर इज द प्रब्लम हैन एन्ड व्हाट वर्क्स एन्ड व्हाट डजन्ट वर्क भन्ने कुराहरुमा उहाँहरुले चाहिँ त्यसमा आफूलाई इम्पावर भएको फिल गर्छ। त्यस्तै गरेर चाहिँ यो चाहिँ अलिकति कल्चरली सेन्सिटिभ इस्यु भएको हुनाले अब यसलाई चाहिँ अब कसरी चाहिँ यस्तो च्यालेन्जलाई हामी हल गर्न सकिन्छ भन्ने कुराहरु आयो र यसमा एउटा मेन कुरा चाहिँ के छ भन्देखि छौपडीको उहाँहरुले चाहिँ त्यो बोथ पोजिटिभ एन्ड नेगेटिभ एस्पेक्टहरुलाई चाहिँ उहाँहरुले चाहिँ केलाउनु भएको छ कि पोजिटिभ एस्पेक्टलाई पनि हेर्नु भएको छ र अब त्यो पाइलट पछि चाहिँ अब मेरो सिद्धिसक्यो सायद यो लास्टै चाहिँ स्लाइड होला। अहिले चाहिँ त्यसैलाई बेस गरेर अर्को एउटा ग्रान्ट चाहिँ त्यही टिमले राखेको थियो र अहिले चाहिँ यो 5 इयरको लागि नेशनल इन्स्टिट्युट अफ हेल्थ यो चाहिँ यो फोगाटी इन्टरनेसनलले 5 वर्षको लागि चाहिँ अर्को एउटा फन्डिङ दिएको छ। त्यो चाहिँ सुदूरपश्चिमको 5 वटा 6 वटा जिल्लाहरुमा केस कन्ट्रोल डिजाइनमा गर्नलाई गइराखेका छौँ हामी र त्यसको चाहिँ एथिकल एप्रुभल एनएचआरसीबाट पनि भइसकेको छ र मैले अहिले यति नै अपडेट गरेँ यहाँहरुलाई। थ्यांक यू।
Thank you so much, Professor Devkota. यो पनि एउटा चाहिँ अलिकति कम रिसर्च भएको एरिया नै हो and then on top of that you have try to use human centered approach design मा intervention मा मैले सरलाई यति मात्रै भन्नु चाहे अहिलेको हिसाबले I think you have done this pilot type of exploratory study and then now you are getting K01 grant. I saw that, NIH को K01 grant. तर menstrual stigma को framework यदि हेऱ्यो भने there are two issues that is grossly missing from the conceptual framework. The one is environmental. Now the people talk about injustice, environmental justice. When we talk about menstrual hygiene ko perspective ra त्यसको stigma को perspective ले त्यो एउटा चाहिँ largely lacking छ conceptual framework मा. How we are going to address that in your K01 team मा चाहिँ अलिकति मैले अहिले भन्न चाहे यहाँ मौका पाएको बेलामा. And the second is if you look at Africa मा lot of intervention भएको छ. The intervention मा other topic is missing in intervention which I couldn't see in your presentation is pain management. हाम्रो menstrual health hygiene जति पनि नेपालमा कार्यक्रमहरु भएको थिए स्पेशली स्कुल एब्सेन्टिजम घटाउनको लागि focusing on other aspect including छाउपडीको हैन छाउपडी भत्काउने त फेल नै भयो त्यो गभर्नमेन्टको प्रोग्राम. तर if you look at the data actually stigma varies type of stigma. तर if you look at the rigorous evidence pain is one of the second major reason why there is a school absentees, which is grossly lacking from the conceptual framework entirely. Menstrual hygiene, health, rights को कुराहरु गर्दाखेरि त्यो कुरामा अब इन्टरभेन्सनको डिजाइनमा यो K01 मा I'm sure हाम्रो तपाईको कोलाबोरेटरले पनि त्यसमा हेरिनु भयो होला कन्सेप्चुअल फ्रेमवर्कमा. These are the two things इन्क्लुड गर्नुपर्ने लाग्छ. अब यति मात्र भन्न चाहे. अब लास्ट बट नट द लिस्ट प्रेजेन्टर हाम्रो सुलता कार्की हुनुहुन्छ. She will be talking about effective coverage of births in health facilities in Nepal. Sulata ji.
Thank you, respected chairs. Namaste and good evening, everyone. I am here to present on a study, effective coverage of birth in a health facility in Nepal. It's a cross-sectional study combining demographic and health survey and health facility survey of Nepal. These are the two recent survey of Nepal. Sorry. Sorry. Moving forward with the background, Nepal has seen a significant progress in increasing the percentage of birth in health facility. Nevertheless, we have still a challenge to achieve the maternal mortality reduction as per the Sustainable Development Goal by 2030. So merely measuring the crude intervention coverage such as percentage of birth in health facilities doesn't always account into the quality of care. So we need to focus more on quality to improve and reduce the maternal mortality ratio. As evidence suggested that factoring in quality of care significantly reduces effective coverage of maternal and child health services. So this study aimed to estimate the effective coverage of facility-based childbirth in Nepal. So we used the two national surveys of Nepal, Nepal Demographic Health Survey 2022. From this survey, we extracted the data on women's characteristics and self-reported place of birth and person assisted during the delivery. And this total sample was 1977 women. And from the health facility survey 2021, we extracted the data on inventory of equipment and types of health provider. So the total sample was 804 facility offering the childbirth services in Nepal. For the data analysis, we separately analyzed the demographic health survey data and then health facility survey data, and then we combine these two data to estimate the percentage of birth in different facility and also to estimate the national coverage in an enabling environment in Nepal. This table shows the definition of enabling environment indicators for routine delivery and for BMOC and CMOC signal function, that is basic and emergency obstetric and neonatal care services. From the DHS results, this bar diagram shows the percentage of birth by person and place. Here I want to highlight the key findings only. Among the birth in government and private hospital, majority were with the doctors, and regarding primary healthcare centers, more than 50% were with nurse or auxiliary nurse midwives, and in terms of health post, more than 90% were with nurses and auxiliary nurse midwife. Now coming towards the health facility survey results, this table shows the percentage of facility type with enabling environment for routine delivery only, and 36.6% of government hospital, 29.5% of private hospital, and only 10% of primary healthcare center had all enabling environment indicators for routine delivery. However, none of the health posts were enabled for all these indicators to perform the routine delivery in Nepal. And some of the key indicators that were not available in the health facility were improved sanitation facilities, communication services, equipment such as suction apparatus and all, and these types of indicator varied among the facility type. So for the BMOC and CMOC signal functions, only more than 20% of facility, that is government and private hospital, were enabled for this functionality. Now combining the results of demographic health survey and health facility survey, the reduction between the crude and effective coverage significantly reduced from 36.8% to 13.5% in government hospital, from 16.1% to 4.7% in private hospital, whereas from 20.1% to 0% in health post. So this seems that when we calculate the effective coverage, it seems that still we need to focus more on quality. Though we have improved the percentage of birth, that is institutional delivery in health facilities. This is the table where the calculation of effective coverage is done, and this is just for the sample example. For the national effective coverage, since we have like 80% of the delivery in institution, but when we calculate the effective coverage, it seems that only 18.5% of birth with skilled birth attendant in health facility were equipped for routine delivery, and it further reduced to 12.9% and 12.2% for BMOC and CMOC functionality. So finally, to conclude, this study revealed deficient in essential indicators across different facility type for to provide the enabling environment for routine and complicated childbirth. And when combining these two surveys, it suggests a reality where out of 10 births in every facility, only 2 births were in a facility with SBA and in enabling environment. So this study can contribute valuable evidence to the policymaker to urgently focus on improving the enabling environment indicators for childbirth. And it's not always enough to focus on expanding the crude intervention coverage. Equal emphasis need to be given to towards improving quality of care in facility. I would like to acknowledge Institute of Tropical Medicine, due to which I get funding to attend a course on demographic health survey, and this is the output of that course, and GUESS Venture and USA DHS program. Thank you so much.
Thank you so much, Sulataji. I think this is very, very interesting presentations combining DHS and facility survey. मलाई चाहिँ अलिकति effective coverage भनेको अलिक बुझ्न गाह्रो भयो. So how this is defined भन्ने कुरा maybe मैले पढ्नु पर्ने होला. Effective coverage को definition, how you actually define that is international, and then adapt in our context होला, how we actually use that word. होला त्यसले नै होल तपाईको एनालाइसिस र रिजल्ट्समा र भोलिको पोलिसी मेकिङमा काम गर्ने होला लाग्छ होला यो रिजल्ट्स पनि लाग्यो मलाई. अदरवाइज आई थिंक the approach you have taken, the intention, what you want to show is, I think, is innovative. With this very short note, र समय निकै घर्केर गइसकेको हुनाले चाहिँ I would like to pass my co-chair to, if he allows to take some questions or not. If not, then he will give our closing remarks. Is now handing over to co-chair.
के छ तपाईहरुको विचार? टाइम धेरै भएको छ है. त्यसो भए कसैलाई के इस्यु छ भने दुईटा क्वेशन लिनु नि त. The floor is open.
It was very nice program. So I would like to ask a question, please. Pretty large. Presentation very important.
Study area. Okay, thank you. It was very nice presentation from you. So here I would like to know about, I was just curious, what was the availability condition of contraceptive and different type of contraceptives and proper counseling facilities by professional health personnel in the study area, so that it can have huge impact on the usage and non-use of the contraceptive in a proper way. So please.
Thank you so much for your question. Actually, we were more, we went to the community, and women of reproductive age were our study participants, so we didn't really do the health facility assessment for this particular research. So the availability of contraception, I cannot be sure and tell you about that. Sorry for that, but thank you. That might be the next research topic or area of research. Thank you.
Okay, this is my turn to close. I would like to congratulate all the presenters for their excellent presentation. I'm not going to comment on individual presentations since Dr. Mahesh has done this very well. So I'm not going to repeat that. With congratulating all the presenters for their presentation, I would like to conclude the session.
Thank you. Thank you, our co-chairs, Dr. Lakshmiraj Pathak and Dr. Mahesh Puri, and all the presenters, Dr. Khembahadur Karki, Mr. Bikram Adhikari, J.D. Shrestha, Kriti Lamichhane, Nansa Maharjan, Priyanka Timilsena, and Bhimdev Kota, and Sulata Karki. And also thanks to Sunita Baral, Asta Acharya, Sujata Dahal, Kusum Shahi, Ankit Acharya, and the entire team arranging this session to success. Thank you, and have a good evening. And we will be meeting you, or Hoping to meet you tomorrow after this photo session. Thank you very much.